Hi, I'm Jenny Thomas. I'm co-producing FemTech TV with Catherine from FemTech Insider. My day job, I'm the director of Digital Health London, and we support startups through our accelerator program and launchpad. And we also work with NHS staff, supporting them with digital transformation projects through our Pioneer Fellowship. And we do a lot of work on evidence generation in digital health. But my personal passion within digital health is FemTech. And I'm on a bit of a mission, really, to really start a conversation in the UK about FemTech and how FemTech can help lots of different healthcare organisations and, of course, women. So I'm really excited to be here today interviewing Alex Davidge, who is the Deputy CIO at HCA, which, as I understand, is the largest provider of privately funded healthcare in the UK. It would be really good to hear today what their thoughts are on FemTech and perhaps some of the pain points that they're experiencing too, where they feel that there are real opportunities to do more in this space. So thanks so much, Alex. It's great to see you again. It's been a little while. You've grown a beard, a lockdown beard.
Yeah, I've got the full lockdown beard.
Yeah. So thank you so much for joining me, giving up your time. Perhaps if we could just start, you could just share a little bit about yourself and your role at HCA and anything you want to say about the organisation too.
Yeah, sure. So, so HCA, it's the world's largest private healthcare kind of provider. So I work with the kind of UK division. In the UK, it's a mixture of outpatients. We have kind of 6 fully owned kind of private hospitals in the London area, including the Portland Maternity Hospital. A number of diagnostic centres, joint ventures with the NHS, particularly in areas around kind of cancer treatment, things along those lines. And from my role within that organisation, pre-COVID, it was the head of kind of strategy and innovation, focusing on the technology side. But since that point, it's gone into a deputy CIO, as there's a lot of generalized work which comes along with that.
Yeah, I can see why that happened.
Yeah. But yeah, so the innovation piece has taken a necessary kind of course correction of how it should.
What's kind of happening, isn't it? I guess.
Yeah, it effectively moves from the planned, governed, disciplined view to very rapid solution delivery, 2-week sprint turnaround times to kind of get solutions out the door to deal with, creating low touch point environments, digitization, virtualization of interactions with, patients, staff working from home, that sort of thing. And I imagine kind of next year will kind of creep a little bit back more towards the backlog planning type approach to innovation work. But yes, it's been, as with everyone, it's been an interesting year, but the focus is broadly within IT, but that focus around innovation and product market problem solution fit is still very much there.
Thanks so much, Alex. Yeah, well, that's why it's really good to talk to you today. So could you tell us a little bit about what are the topics that HCA or you are excited about in FemTech? Yeah,
so there's kind of from an HCA perspective, obviously we have the Portland, and there's a big piece there, I think, around kind of postnatal. So obviously that's an inpatient piece. There's stuff which is being done, which we're kind of getting a lot of value out. The silver lining, I guess, associated with COVID around post-discharge, remote teleconsultations for kind of wound monitoring between kind of mothers and nurses or consultants, things along those lines. That's opened up a whole bunch of opportunities and kind of questions around how we deal with things like teleconsultations. There's a lot of questions it opens up, right? Such as, how do you deal with safeguarding? Are there things that you can do that you couldn't do before, which is great, but what are the challenges that you now have in teleconsultations? And that's a space both within the FemTech space and the wider space, which I think is ripe for people to kind of explore. But certainly on the postnatal side, we in both within HCA and kind of previous organizations, we know that there is the Little Red Book, digitizing that capability. There's been various ventures around that, but the Little Red Book is based around the physiological development of the baby, which is nice and predictable, and that's great. But there is still that space there around, okay, well, what about the physiological and psychological, postnatal journey of the mother or the father or the parents? And that's not really attended to. And that interaction point with a physical or digital little red book is just, it's crying out for more investment, more capability, and more attention to how you track the baby's journey, but the mother's journey, in parallel along with that. So that's an area from a maternity perspective we're focused on. I mean, at a personal level, there's a space, and it's increased with demand post-pandemic around teenage girls' mental health. So adolescent girls' mental health. And one of the things which has been, kind of identified as the demand for CAMs versus the resources they've got have shown a massive disparity between demand and supply. It's unearthed that there's actually a real problem with kind of diagnosis for teenage girls in certain areas around mental health, particularly within autism ADD. So teenage girls present differently for those sorts of kind of diagnoses. And the way that those are scored, if you can get through to CAMs, which is a challenge, not blaming CAMs, it's the demand side, that a lot of the scoring, a lot of the assessment, initial filtering and screening is really geared around diagnostic scores and quests, which are kind of geared towards boys. So a lot of girls are actually failing to get appropriately diagnosed, and therefore the treatment and interventions will necessarily not be fully appropriate as well. And there are a wealth of stories out there of women who are getting into their 20s, 30s, 40s, and then getting a diagnosis at that point because it's simply not picked up early and simply inappropriately diagnosed. So that is a space, I think, if you're talking about kind of entrepreneurs out there who are looking at where FemTech digital health could be, there is a space there which is, I believe, entirely unoccupied. So if anyone's looking for a kind of a pivot or a kind of a side hustle for their organization, they should have a look at the whole teenage girl autism diagnosis challenge.
Thank you so much for that, Alex. I think that's really interesting, and as we kind of spoke earlier, that isn't. I'm not aware of a solution out there that does that, but maybe someone who's listening is.
Yep.
This is why I love talking to people, whether that's within the NHS or within private healthcare like yourselves, because just really surfacing those pain points, to others so that they can hear, and they can hear it firsthand as well. I mean, the example you gave on postnatal kind of led to us having a chat about one of the companies that's on the Digital Health London Accelerator at the moment, Peppy Health, and whether or not that kind of fits exactly, but at least it gives you something to kind of to look at and consider, and kind of help you on that journey to finding solutions. So,
yeah, no, absolutely.
Thanks so much for that. So in terms of, I guess, digital health startups, but also specifically FemTech, I mean, what do you do to kind of understand what's out there? Kind of how do you connect with organizations? How do you have that kind of external lens? I appreciate, you being so busy.
Yeah. I'd be lying if I
said a lot of that, didn't you, in your previous role?
Yeah, I would say I'd be lying if I said I'd done a lot of that since March. But more broadly, when things kind of slightly shuffle towards normal, right, or shuffle towards whatever the future is, I mean, ultimately it has to be around kind of networks, and whether that's organizations like your own, which are is a rapid sudden exposure to a whole bunch of organizations who may be able to help with the sorts of challenges that we've got, and invariably those networks interact with each other. So there is the mathematicians will hate me for saying I'm using this word inappropriately, but there is an exponential benefit to getting involved with some of those sorts of networks. So that would be the kind of the normal kind of course of action. The other element in reality is that we have a lot of clinical practitioners, a lot of the consultants who work with us, and they will move and have interactions in their specialist fields. And they will come across organizations because they are, focused, whether it's from a research perspective or from a practicing perspective. They'll come across a number of organizations where they say, actually, this is a way of ameliorating or even kind of solving a problem which hasn't really been properly addressed. And one of the plus points, I think, within kind of HCA is we have a very good kind of flow between the technology world and the IT world and the clinical world, both in the day-to-day BAU of where there are opportunities or challenges to be addressed, as well as things which may come down the line. So a lot of that information kind of flows to us. And it then gives us an opportunity to say, okay, well, it's worth speaking to these guys. The challenge always is how much time in the day you've got to do it, right? So,
exactly.
so there's a little bit of
How does
filtering
that
and
flow
screening.
work?
Sorry?
There is how does that flow work? Is there more structure?
No, I mean, some of it is really around the fact that we have I think kind of certainly a relationship with our consultants. So each of our facilities, so if we take the Portland, for example, you will have a number of individuals who are direct kind of access points into those consultants. And some of that, again, will be dealing with kind of day-to-day challenges or opportunities that we need to kind of, support them with. But it also means that they kind of build those relationships up almost as kind of liaison managers for those consultants, or development managers for their practices, as to how those might be expanded or kind of diversified. So all of the, I guess, all the opportunities the consultants see are something that we may wish to pursue. They have those access points at the facility levels where they practice. And that smaller network then, so it's not a hierarchy, but it's a node. Those guys are effectively then nodes into, our head of clinical technologies, or into the IT organization. So again, it comes back to networks, right? It's those kind of key nodes internally and externally, and how they connect into each other. And eventually, I have 1,000 things on my backlog, and I have to figure out which one or two I might need to have a look.
Yeah, do first.
Yeah.
Kind of fast stream, slow stream, quick wins, and all that.
Yeah. Everything goes onto a 2x2 at the end of the day, right?
Yeah, exactly. So, I mean, you touched on this a little bit earlier, but is there anything else you would share in terms of particular successes on the, ideally on the FemTech side, but appreciate.
Yeah, and it is kind of quite interesting, because I think obviously everybody's gone into just work, from a healthcare perspective, a lot of teleconsultation. And that's been hugely, I think, kind of valuable, because it provides in many respects a level of access which sometimes isn't really that straightforward. And that's not just within the Portland and its maternity spaces, that's in all manner of kind of healthcare. And that's been hugely valuable, I think, in creating kind of low touch interactions minimizing the physical interactions between individuals, until there's a need to, so to speak. That's not to limit those physical interactions, because in some cases they're very much required. And that massive move to kind of virtual consultation, virtual discharge, remote wound examinations, things along those lines. Obviously, it gives not just assurance that the care is still going on, but it takes out a lot of the worry from the patient's perspective about having to do unnecessary travel. Right? They may feel happy in the facility, but it's getting from A to B. And I think, as everybody kind of knows, and it's a generalization, so I apologize, but as everybody knows, at a general level, a lot of healthcare decisions and a lot of healthcare worries, like who holds the worry in a household, sits with the mother or the matriarch or that kind of female figure within the household. And that comes from everything from nutrition decisions to healthcare choices, making the appointments. The male of the species is not particularly good at that, and has not been particularly kind of good at that, and that arguably should change. But when you come to things like teleconsultations, that gives a little bit of empowerment, I think, to those healthcare decision makers within a household, to be able to say, well, there's really no excuse for not having this appointment. Like, this can be kind of readily managed.
And I guess it also makes that access bit better for genders as well, because sometimes it's about, who can take the time to travel to the appointment, or
exactly
a child or an elderly relative.
So I think not on the FemTech side, but in terms of kind of benefits to those health decision makers, typically matriarch kind of decision makers. There's a definite boon there. It takes some of that pressure off. And that's it's a great thing in general. But knowing that there is this kind of additional kind of side benefit to the main worry is about the family's health is a benefit. But as I say, we were talking earlier about the teleconsultation piece. It again opens up kind of new opportunities for kind of entrepreneurs or organizations to think about, well, what are some of the new problems kind of coming up there? So if you have the health decision maker is typically a matriarchal figure, a female figure within their household, when you're having one-to-one interactions like this, does that? Are you
about to talk about how my kid just ran in?
Yeah. So I mean, it's a good in some respects, but it also kind of creates then challenges around, okay, well, do they end up are more invested in those conversations because they can be part of that consultation more easily, right? They can be there more easily if it's their partner's health or their children's health, and obviously they'd normally be with their children anyway. So there may be some kind of unintended consequences to the whole teleconsultation phenomenon, which will be around now in a much more prevalent way, that haven't yet been kind of picked up. We can't physically give people pamphlets explaining particular diagnoses or conditions and things. So when that call ends with a physician, maybe with best intent trying to convey things in very layman's terms, has that translated? Has the person only really understood it? There are some a little bit of an unknown questions out there, but the access piece is is absolutely kind of huge, and that's that's a real kind of benefit, I think. I mean, one of the certain things which I think with some of these kind of small challenges with teleconsultations, whilst we're and not just with the consultants, it's post, it's like, as I say, wound examinations, for example, conversations with nurses. One of the things that we kind of are aware of that I think is particularly relevant from the female side of things is around safeguarding. Excuse me. So in the physical interactions, the opportunity to identify potential kind of risks of abuse, that becomes a little bit more prevalent. Seasoned practitioners will have been trained to look for those signals and to ask the right questions. Those signals are less prevalent within teleconsultations. There are hand signals and gestures which can be made by women to signify that they are in some form of situation of domestic abuse or kind of domestic danger. With a consultation with a consultant, we make sure that everybody's.
Do you know what that hand signal is, by the way? Because
I'm wary of getting it wrong, but I believe that it's, so someone may need to validate. I believe that it's a hand close. The thumb goes into the hand and then it's closed over like that. So it could arguably be done kind of quite casually without signifying something, but someone will need to validate it. It's been a little while since we picked it up and kind of rolled it out, but something's going to be aware of. But yeah, so I'm 90% certain, but someone will need to kind of validate that, and if they can, and if this gets posted, and someone knows what the
fact that you've done it, like that raises that there is something, right? So for anyone that's listening, that could be experiencing anything like that, actually knowing that sort of thing exists.
Yes, and that should get picked up. So so it's a constant from an innovation perspective. It's a constant. It's great that these achievements and these things are happening, particularly not just dealing with the pandemic, but as a constant examination of what new opportunities, what new challenges is it raising, what things have to be fundamentally different. And from a technology and innovation perspective, there's a lot of opportunity for organizations out there to look at the broad topic, and it may be by particular specialism, could be gynecology, whatever else, things on those lines, and ask that broad set of questions. What is the problem solution fit and the product market fit between teleconsultation in that field? Because
that's really interesting, because I guess that sort of leads on to sort of the last question I wanted to ask you in terms of kind of what's next. And what's next for FemTech? Do you, and I know from what we talked kind of the first time years ago, you described to me sort of your kind of vision around a kind of innovation, like governance process. So it wasn't all scattergun, that there was some real methodology behind it, which I thought was fascinating. What do you think, in answering that question, kind of any good practice that perhaps when you're a bit less crazy, that you think about in a women's, for the women's health element of your business at HCA?
Yeah, and I think a good an angle of it. So if I think about more broadly first around when we think about digital capability within kind of HCA, a lot of it, as everybody will know who's gone through any type of kind of pathway or kind of care journey, is an end-to-end journey from the patient's experience is typically disjointed. From the moment being worried well to looking for some information to getting an initial referral, a consultation, then maybe some diagnostics, then maybe further diagnostics, then treatment, then discharge, then recovery. The likelihood that is a seamless process, like being managed through the rides at Disneyland or through through the floor arrows in IKEA, it's not a navigated process. There's lots of gaps in between. There's lots of unknowns and uncertainties, and whilst all this is on top of having to worry about health. So digitization around dealing with that kind of helping to manage that kind of horizontal journey for the patient, and applying the right digital touch points through the journey by condition, information, explanation, helping them understand what's happened, what's happening next. That is an area that we're kind of looking at quite keenly. And that's not just the non-clinical parts of the journey, right? So if we're talking about private healthcare, it's how you may interact with an insurer, or if you're looking at kind of self-payment for diagnosis, for example, things like that. And I think kind of going back to that, there's orchestration of the patient journey, which typically is between the provider and wherever a source of funding comes from. So NHS and government, private healthcare and insurer, or things like that. And that's fine for orchestration of the care of the patient. But then there's also that element of going back to that notion of the matriarch, or the health decision maker within the household, which isn't always going to be a kind of a matriarchal role. That orchestration piece has a different level. It's beyond just, yes, let's knit some parts of process together. It starts to get to a position of saying, okay, well, if you're an organization which is trying to help manage the patient to the right healthcare outcome, or thinking about how you can maintain a long-term relationship with the patient where they get a good experience and they see that there's value and they want to come back. There is a notion that you might be doing a lot of great stuff for the patient, but if the patient is not the person, whether it's a child or a partner, or if the patient is not the healthcare decision maker, if the patient is not ultimately the main arbiter of health for a household, you've successfully managed to influence and yeah, what are you solving, right? You're basically trying to navigate someone who doesn't have the decision making to necessarily do that navigation. So you have to target you have to go beyond looking at the patient as a clinical entity being pushed through a factory. You need to start looking about the patient as a person with experiences and their own household and their own lives, and what are the influences,
the role that women have in that.
Exactly.
Usually, not always the case, for sure.
So
not in my household. Interestingly, my husband's incredibly my son's healthcare. But yeah, I think that you really have to kind of identify kind of the customer through that lens as well.
And in the conversations we've had previously, I think you've quite rightly said that the organizations which are getting on the front foot with FemTech or the concept of FemTech even will start to have a material advantage. And in healthcare, when you think about healthcare decisions, what choices get made? What do people spend their money on? What are people willing to put their time and effort into? Not all, but a significant portion of those decisions, whether they are the patient themselves or not, a significant portion of those decisions will be made by a kind of a lead female figure in a household. And that's a global kind of phenomenon that has various different manifestations in different cultures and levels of kind of prosperity in countries. But that is a broad consistency kind of globally. So this isn't just like a UK healthcare, go to the doctors phenomenon. This is a paradigm, right? It's a very entrenched, deep socio-cultural, socio-economic kind of phenomenon. And if we're blind to that, then we're going to be chasing a lot of dead ends as as an ecosystem.
And I think you're right about the it's certainly not just the UK in many ways, that it kind of happens even more in the developing world.
Absolutely.
Doesn't it? So yeah, I'm thinking about the future of healthcare, and it being probably, there will be, I'm sure, very different and much less focused on geographies, and much more kind of on how the kind of democratization of healthcare really helps people in much more consistent ways across the world. Well, Alex, thank you so much for your time.
No, thank you.
I really appreciate you sharing all your thoughts and insights. It's been really interesting, and I'm sure everyone listening has enjoyed it and has definitely learned something from the conversation.
Yeah, even if it's a possibly correct safeguarding hand gesture, right? There'll be something to take out of that. Please validate that gesture. All right.
Thank you so much, Alex. Really, really grateful for your time.
All right, thank you.